So, as you know, this is our first time meeting in person, but we have had the pleasure of having 2 virtual meetings before this one. And for those of you who attended the first virtual meeting, you may remember the rousing update in Deprescribing research, gamified version presented by the esteemed Dr. Amy Linsky and Dr. Kristin Zimmerman. And we were thrilled when they accepted our invitation to come back this time as a repeat performance. So Amy Linsky is assistant professor in general internal medicine at Boston University and VA Boston Healthcare System. Kristin Zimmerman is an associate professor of pharmacy at the Virginia Commonwealth University. They are fabulous people, fabulous presenters, and we're so glad that they are here to kind of close out the day. So Kristin and Amy, thank you.
Thanks, Mike. Appreciate that. Maybe we should not have set the bar so high 2 years ago. But Chris and I were really thrilled to be asked to come back and talk again and talk about updates in deprescribing research. This time around, we will hopefully be finding the magic.
Playing on the Disney theme, of course.
Before we begin, no conflicts of interest. These reflect our views, not necessarily those of the Department of VA. So we have some objectives. Got to have a sense of what you might learn over the next 45 minutes. So first, we want to highlight some recent medication discontinuation studies. We'll then move to discussing the key findings of pragmatic deprescribing intervention trials. Finally, we will evaluate the economic impact of deprescribing. Putting it all together, we'll hopefully be able to unsnow Snow White. So we will be using a bunch of abbreviations on these slides from the content of the day thus far. I'm guessing most of you know pretty much all of these, but just in case, we'll give you about 5 seconds to scan through them. All right, I'm going to hand the baton. Neither of us were track runners, so hopefully no dropping.
Hopefully. So it's incredibly appropriate that as the pharmacist member on this duo, I get to lead us off by talking about recent medication discontinuation studies that came up in our look back period, which was September of 2020 through March of 2022. There was so much great research for us to read through during this time point, and we're thrilled that there's actually a couple of researchers that we feature today here in the audience. So Jim McDonald, Jim Shepard, where are you? I think I saw you earlier. Yes. So we're going to be featuring one of your highlights today. So hope that you and others who we feature today will partake in our Q&A and provide us some additional insights on your work, and certainly correct us if we misrepresent anything relative to your prior research. So I will kick us off. Once upon a time, when Amy and I gave our last update, we talked in great detail about the optimized trial. Today, we the optimized trial evaluated the effect of deprescribing a single antihypertensive versus usual care in patients aged 80 and above with controlled systolic blood pressure receiving 2 or more antihypertensives. Ultimately found no difference in systolic blood pressure control or clinical outcomes at 12 weeks following antihypertensive discontinuation, despite an increase in systolic blood pressure of about 3.5 millimeters of mercury. So ultimately showed us that deprescribing a single antihypertensive in this patient population was at least safe in the short term. So today, I want to focus on an exploratory analysis of data from the optimized trial, evaluating whether these same short-term outcomes varied by antihypertensive drug class or drug dose. So the methods of this evaluation are, of course, essentially identical to that of the parent trial, with the exception of these exploratory outcomes, evaluating for between-group differences in regards to systolic blood pressure control, adverse drug events, and changes in blood pressure values between antihypertensive drug class and antihypertensive drug dose. Now, for antihypertensive drug class, study authors compared calcium channel blockers, ACEs and ARBs, diuretics, beta blockers, alpha blockers, and a kind of catch-all category of other antihypertensives. And those medication classes were consistent with the structured medication reduction algorithm utilized in the trial and outlined here for you on the slide. wherein antihypertensives that were considered potentially inappropriate per the STOP criteria were recommended to be considered for deprescribing first, followed by fourth-line antihypertensives, and right on down the line where calcium channel blockers would be recommended for consideration of deprescribing sort of last in line. Now, relative to the dose comparisons, the authors utilized the WHO defined daily dose threshold, considering medications that were prescribed at 1 or more of the defined daily dose to be considered high dose, and those at less than 1 defined daily dose to be considered as low dose antihypertensives. I'll present the results by dose first. Deprescription of antihypertensives that were prescribed at 1 or more defined daily dose, so that high dose, was associated with an increase in systolic blood pressure of about 4.7 points, but not associated with a difference in overall systolic blood pressure control. Deprescription of low-dose antihypertensives, less than 1 defined daily dose, was associated with a significant increase in the risk for adverse drug events, which included any clinical event occurring during trial follow-up. Relative to antihypertensive drug class, I want to talk about sort of two ends of the spectrum from this evaluation. The first is discontinuation of beta blockers. Discontinuation of beta blockers was not associated, with an overall change in systolic blood pressure control or blood pressure values. But interestingly, the direction of change for systolic blood pressure following beta blocker discontinuation represented a decrease in systolic blood pressure. Was also associated with the highest rate of maintenance of discontinuation, meaning that very few patients needed to restart an antihypertensive following discontinuation. Now, this is in contrast to the other end of the spectrum, where we see that for calcium channel blocker discontinuation, discontinuation was associated with an overall decline in systolic blood pressure control and one of the lowest rates of maintenance of antihypertensive discontinuation, meaning that patients more frequently needed to restart an antihypertensive to maintain control. The other drug classes that were compared fell somewhere in the middle of these two ends of the spectrum, with no association in overall systolic blood pressure control, blood pressure change, and with fairly good rates of maintenance of discontinuation, anywhere from about 65% to about 80%. Now, thinking about the drug doses of each of these classes, for patients who were prescribed beta blockers, low-dose beta blockers were more often selected for discontinuation than were high-dose beta blockers. The opposite is true for calcium channel blockers. High-dose calcium channel blockers were more frequently selected for discontinuation than were low-dose calcium channel blockers. So that selection of high-dose calcium channel blockers possibly could have contributed to the findings relative to the overall decrease in systolic blood pressure control following discontinuation. So what does this mean? The original evaluation of the optimized trial showed us that it's not inherently harmful, right, to discontinue a single antihypertensives in patients like those evaluated here. But I think that this exploratory analysis addresses the point that Barb had brought up earlier today. How do we think about finding the data and conducting the research that helps us drive deprescribing decisions? How do we approach formulating deprescribing guidelines and selecting which medication to discontinue? I think that this exploratory data helps perhaps guide us to considering letting the beta blocker go, if you're a Frozen fan like my 3-year-old daughter is. And perhaps we consider discontinuation of calcium channel blockers sort of last in line for antihypertensive discontinuation if our goal is overall for the patient to maintain their systolic blood pressure values. So next I want to talk about the ANTLER trial, which evaluated the effect of discontinuing antidepressants in primary care. This multi-center randomized double-blind placebo-controlled trial was conducted in the UK. It included adults who had had 2 or more prior depressive episodes or had been on their current antidepressant for 2 or more years, and importantly, who felt well enough to discontinue. Patients could not have current depression at trial entry. Patients were randomized to either taper or continue their antidepressant and were followed for a total of 52 weeks. Patients included in this evaluation were largely in what I would consider early late life, so in their mid-50s, were largely female, and were largely white, consistent with what we see in a vast amount of the deprescribing literature. Patients also largely had long-standing history of depression with a mean age of onset of 33 and 32 years. So greater than 90% of patients had also had 3 or more prior episodes of depression, and greater than 70% of patients had been using their current antidepressant for more than 3 years. So really getting to this idea of long-standing history of depression and multiple prior episodes. Patients who had been randomized to discontinue their antidepressant, a greater proportion of those patients experienced relapse over the 52-week time period. Discontinuers also less often adhered to their trial assignment and more often restarted an antidepressant. At week 12, discontinuers also had greater rates of depression, greater rates of anxiety, and worse global ratings. Now, these differences were a little bit muted as the trial wore on, likely because those patients who discontinued their antidepressant more often restarted an antidepressant and less often adhered to that trial assignment. Next, I want to focus on statins, which has been a bit of a hot topic that we've heard a bit about today. And I want to present 2 evaluations of statin discontinuation side by side, because there's some pretty interesting points of comparison and contrast here. So the first evaluation by Rhea and colleagues sought to assess the clinical implications of statin discontinuation in older adults receiving polypharmacy, which, as we'll see in a second, importantly included chronic cardiovascular medication use. An evaluation by Thompson and colleagues evaluated the association of statin discontinuation and the rate of MACE among older adults receiving statins long-term. Both of these evaluations were retrospective cohort studies. They both utilized national databases, so a bit of another theme that we've heard today. And they both compared 180 days of statin discontinuation versus continuation. The study by Ray and colleagues was conducted in Lombardy, Italy, included patients aged 65 and up who had been not only receiving statins, but also receiving antihypertensives, antidiabetics, and antiplatelet agents continuously. So patients who discontinued their statin continued the antihypertensive, the antidiabetic, and the antiplatelet agents, really trying to isolate for that statin-related effect. The evaluation by Thompson and colleagues was conducted in Denmark and focused on a bit older patient group, those aged 75 and up who had been taking statins for 5 or more years and who also had a medication possession ratio for that statin of greater than or equal to 70%. And they present data for statin indication, so we get to see some data for folks taking statins for primary prevention versus secondary prevention and what happens when that statin is ultimately discontinued. The demographics of each of these study populations are relatively similar, mean age and sort of that mid to late 70s, early 80s. The study by Rhea and colleagues included slightly more men than did the study by Thompson and colleagues. But one thing that I think is really interesting about this study by Thompson and colleagues is that they do present the rates of statin intensity prescribed in each of these groups. And I was really surprised to see very low rates of high-intensity statin prescribing, even in the secondary prevention arm. It should also be noted that the follow-up period for Thompson and colleagues was also notably longer than that for Rhea and colleagues. The overall proportion of patients who ultimately discontinued a statin over the trial period was pretty similar between each of these trials. About 20 to 30% of patients over the follow-up period ultimately discontinued their statin. The study by Rhea and colleagues found a statistically significant increase in the clinical outcomes highlighted here in red. So statin discontinuation here was associated with an increased risk of death for any cause, composite of cardiovascular hospitalization, hospitalization for heart failure, and ED visit for any cause. The study by Thompson and colleagues also found an increased risk of MACE, or rate of MACE, following statin discontinuation. And for folks who are taking statins for primary prevention, we will see 1 additional MACE per every 112 discontinuations of that statin per year. For folks taking statins for secondary prevention, that's 1 additional MACE per every 77 discontinuations per year. It's also associated with an increased risk for MI, stroke, and death from MI or stroke. So the bottom line here is that in our world of deprescribing, there might still be some pills worth fighting for, if you get the Mulan reference there. This statin data was really surprising because we talk a lot about statins being a common target for deprescribing interventions, and we tend to think of this primary prevention modality as being relatively benign in terms of medication discontinuation, but this evaluation shows us that statin discontinuation in late life may actually increase the risk of MACE and increase the risk of fatal and non-fatal outcomes. So maybe we need to sort of think twice about that risk-benefit trade-off. And similarly, for stopping antidepressants in those who have a history of longstanding depression and multiple depression episodes, that may ultimately increase somebody's risk of having relapse when we're sort of thinking forward long term. And so I think that this type of research, how we think about approaching medication discontinuation, is really useful when we're thinking about giving clinicians meaningful evidence to make their decisions, and we think about deprescribing guideline development.
Great. Kristin, thank you so much for walking us through those clinical studies about medication discontinuation. So next, I'm going to move on to discuss the key findings of pragmatic deprescribing intervention trials. I think many people in this room have probably been waiting for some of these findings. We've seen a lot of pilot studies, a lot of smaller scale studies. These are some of those larger studies that might reflect what's happening in the real world with some interventions. There's going to be 4 studies that I go through. There's a variety, a lot of similarity between them. I'm going to try to highlight the differences as I go through each one. So the first one to talk about is the MedSafer study, which wanted to evaluate the effect of an electronic deprescribing decision support tool on adverse drug events after hospital discharge among older adults with polypharmacy. So to describe the intervention first, this is essentially a clinician deprescribing report that was provided within 3 days of hospital admission, and it prioritized high-risk PIMS, then intermediate-risk PIMS, and then PIMS of little added value. There was also a patient educational material component to it. The control group here, as in pretty much all of these studies, was usual care. This is a cluster randomized step-wedge clinical trial that took place at 11 Canadian acute care hospitals from August of 2017 until January of 2020. The patients were age 65 and up, also a constant theme, and polypharmacy here was 5 or more medications, and they assessed outcomes at 30 days post-hospital discharge. So the patients were primarily in their late 70s, actually relatively evenly balanced between men and women in this study. At baseline, you can see that there was 10 medications in each group, and on average, 2 PIMS per patient. Again, similar between groups. These typically were proton pump inhibitors, sedative hypnotics, gabapentinoids, and diabetic agents in very well-controlled older diabetics. So if you weren't paying attention when Justin stole the thunder earlier, they did not see a difference in the proportion of patients with an adverse drug event at that 30-day mark. Roughly 5% in both the control and the intervention groups had an adverse drug event in that time period. However, for their secondary outcomes, they did show a reduction in the proportion of patients that had at least one potentially inappropriate medication deprescribed at discharge. For all of their other secondary outcomes, they did not see any statistically significant differences. I'm also going to highlight whether harms were found in all of these studies. And in this study, they did not see any difference in adverse drug withdrawal events. So next, we're going to move to the GMEDS study, which is the goal-directed medication review electronic decision support system. And this was another decision support tool that looked at drug burden index among older adults with polypharmacy. The intervention itself was a pharmacist-conducted home medication review plus a GMEDS report that was then sent to a patient's general practitioner. The GMEDS report included a goals of care management tool, a drug burden index calculator, as well as the revised PATD. Usual care was the control. It was a cluster randomized clinical trial that enrolled 53 clinical pharmacists in Australia who conducted home medication reviews from September of 2017 until March of 2019. Again, patients were 65 and up, and they had to be eligible for a home medication review and English speaking. The follow-up was extended out a little bit more compared to MedSafer, and here they looked at outcomes at the 3-month mark. So patients were somewhat in the same age range, again in the late 70s. Here, slightly more women than men. And at baseline, again, 10 to 11 medications, usual medications. So what did they find? So for their primary outcome, which was actual reduction in the drug burden index, they did not see a difference between the intervention group, which had about 17% had a reduction in their drug burden index, compared to 11% in the control group, but this wasn't statistically significant. However, for one of their secondary outcomes, which was a recommendation that would have led to a reduction in drug burden index, they did see that the pharmacist much more often gave a recommendation to the GP that would reduce the drug burden index. So 37% in the intervention group compared to 14% in the control group. For the other two secondary outcomes, there was no difference, either, again, in the change in drug burden index score or in any of the clinical outcomes that they assessed. So next I want to move finally to the United States. You can tell by the spelling of this optimize, which wanted to evaluate the effect of patient and clinician education on deprescribing of unnecessary or risky meds among older adults with cognitive impairment. So this intervention was an educational one, as mentioned. There were two components. The first was the patient and family component, which included a managing medication brochure that was mailed in advance of a clinic visit, along with a revised PATD for cognitive impairment. The clinician component included monthly educational materials, tip sheets, and poster on deprescribing, and then what I actually, as a clinician, think I would probably find the most useful, which is an electronic health record notification of an upcoming visit with a participating patient. Again, the control group received usual care. This was a pragmatic cluster randomized clinical trial of 18 primary care clinics in a large integrated healthcare delivery system from April of 2019 until March of 2020. Patients were 65 years and up. Here they had to have dementia or mild cognitive impairment and at least one additional chronic medical condition, probably not hard to achieve, and then 5 or more long-term medications. Follow-up is extended now even further. We're looking at 6 months for these outcomes. So who got enrolled into this study? Again, kind of late 70s, early 80s as the average age, slightly more women than men. At baseline, patients were taking 7 medications, and about 30% in each group were prescribed at least 1 PIM. So what did they find? So there was 2 primary outcomes. The first was looking at the mean number of long-term meds at the 6-month follow-up, and there was no difference in the two groups, on average about 6.5 medications. For their other secondary outcome, which was how many had at least 1 PIM deprescribed, there was a near statistical significance, not quite, difference in terms of the number of PIMs number of individuals who had a PIM deprescribed. So about 21% of the control, but then it goes down to about 18% in the intervention group. There was also several subgroup analyses looking at these same outcomes. So for the subgroup analyses that looked at long-term medication counts, the 6-month mark, none of the subgroup analyses showed a statistically significant finding. However, when you look at the subgroup analyses for the number of individuals who had PIMs reduced at the 6-month mark, the individuals who are on the higher medication count at baseline, so 7 or more medications, did show a reduction in PIMs relative to the control group. Related to harms, again, there was no differences between the groups in either hospitalizations or in mortality. And finally, I want to talk about the SPIRE study, which was looking to evaluate the effect of general practitioner-delivered medication review to reduce polypharmacy and PIMs in older adults. So the SPIRE intervention notably targeted the GP themselves, the prescriber themselves, which is primary difference I just want to highlight compared to the GMED study, which was had pharmacists that were identifying the potentially inappropriate medications. And this involved some professional training videos that was on their website, as well as a template for doing a SPIRE-guided medication review that involved identification of PIMs, eliciting patient preferences, and a thorough med rec, and really spending extra time with the patient to take a look at their medications and deprescribe PIMs. So it's a pragmatic 2-arm cluster randomized trial of 51 GP practices in Ireland that had to be using one of 2 national practice management systems from April of 2017 until October of 2020. Patients were again 65 and up. However, here, very notably, they had to be on 15 or more repeat medications at baseline. They also used a follow-up time horizon of 6 months. So at baseline, again, in the 70s, a little bit more women, but you can see here that they were taking a lot more medications at baseline. Now, there was actually a statistically significant difference at baseline between the control and the intervention groups. These were adjusted for in all subsequent analyses. There was also a similarity in the number of PIMs at baseline between the two groups. This was about 2.5 per patient. So what did they find? They actually did see a reduction in the number of repeat medications at 6 months. So 16 repeat medications for the intervention group compared to 17.5 for the control group. But they did not see a difference in the number of patients with any PIM. For their secondary outcomes, they also did identify an increase, this makes sense, in the number of medications stopped. And a notable corollary was that there was no difference in the number of medications started. We know that often with thorough medication reviews, you find some gaps in care where you have to add a medication, and sometimes the medication counts actually go up. They also found a reduction in the proportion of patients who had significant polypharmacy, so that there was 63-ish% of the intervention patients still had significant polypharmacy, compared to 82% in the control groups. For their other secondary outcomes, they did not see a difference. Again, wanting to highlight whether there was any harms from these interventions, they did not identify any deaths due to the intervention. There was 15 adverse drug withdrawal events in the intervention patients, 10 of which were probably related to the drug withdrawal, and one of which was categorized as serious, the rest were mild, and they all resolved with reinstitution of the medicine that had been stopped. So, how do we get out from the under the sea of pills? And I will say this, to me, is the Renaissance period of the Disney movies. But unfortunately, the interventions in these studies were generally not able to really improve deprescribing, at least as they were presented here. However, there are some bright spots that I think that we can try and focus on. One is that there were few, if any, harms associated with interventions. We've talked a lot about how clinicians, how patients are very concerned about what's going to happen if I stop this medicine. What potential harm might I be doing to my patients by withdrawing this medication? And there really isn't much, and this is consistent with prior literature, to suggest that we're going to be causing any harm by stopping medicines. There was also a suggestion of benefit in patients with higher number of medications. So thinking specifically at the subgroup analyses in the optimized trial where patients with 7 or more medications did have a reduction in the number of PIMs, and similarly in the SPIRE trial, patients with 15 or more medications at baseline did have a reduction in the number of medications 6 months out. We might be able to better target our interventions at those who will have higher degree of polypharmacy. There's also a suggestion that longer follow-up might might have a better ability to identify benefit of our interventions. So again, both Optimize and SPIRE use 6 months. And so the shorter follow-up of 1 month or 3 months may not be long enough for us to really start seeing some of that benefit. Might be that we need repeat conversations. These aren't a one and done decision making. And so recognizing this could be a more, may take more time longitudinally, can help us with thinking about how we want to design our studies for intervention trials. So again, kind of to reiterate some future focus, we might want to think about specific medications. As Kristin talked about, maybe not all medicines should be targets of deprescribing. We may want to think about the patient population, so thinking about the patients who have more medications at baseline. And also thinking about the prescriber, like who is the actor? Now, a lot of my research focuses on patient engagement and bringing the patient voice into these decisions. But what we saw here was that when the GPs directly were targeted for the intervention, so in the SPIRE study, there was a greater reduction in polypharmacy. Whereas in GMEDs, where it was a pharmacist recommendation, the pharmacists were making the recommendations, but the GPs weren't doing it. So what's happening there? We were talking, obviously, earlier, there's been discussion about how do you get those recommendations for this interdisciplinary care as we think about, obviously, lots of different types of care practitioners to really focusing the intervention to yield those outcomes that we're hoping for.
So do we have any SNL fans in the room? Because if we do, I really feel like that segment that Amy just provided is really consistent with the Debbie Downer segment on SNL, which I think kind of leaves us all a little bit heartbroken in the deprescribing world that we didn't see, these robust, amazing, miraculous results. So I'm hoping that this sort of last segment here might be the bright spot for us to end on today as we evaluate the economic impact of deprescribing and sort of what's new in this realm. So I want to focus on one evaluation that sought to synthesize the economic evidence of deprescribing interventions among community-dwelling older adults. So this systematic review included full economic evaluations of deprescribing interventions that were conducted in community or primary care settings and focused on community-dwelling adults aged 65 and up. The study authors assessed the impact of these interventions in 2019 US dollars and used a willingness to pay threshold of 1 GDP per capita. So ultimately delineating which of these interventions was acceptably cost-saving, as identified in the sort of bottom left-hand square here. Ultimately, just as effective, but saved us a little bit of money. Which interventions were cost-effective in the sort of upper right-hand box, so more effective but also more costly, and which interventions ultimately dominated usual care, so more effective and also reduced cost. There were 13 interventions that were included in this analysis. 5 of those dominated usual care. 3 of those were conducted in community pharmacy settings. Spoiler alert, one of them included the Empower trial and one of them included the Deprescribe trial. And 2 interventions were conducted in outpatient general practice settings. 4 interventions were determined to be cost-effective, one of which was conducted in community pharmacy and was associated with a cost per quality of $18,000 per quality-adjusted life year. 3 interventions were conducted in outpatient GP practices and associated with a cost per quality that was a little bit more variable, anywhere from $434 per quality all the way up to $40,000 per quality. Now, 1 intervention was cost-saving, conducted in community pharmacy and saved a whopping $236.21. Can't forget the 21 cents. And 2 interventions were determined to be not cost-effective because they were above that willingness to pay threshold of 1 GDP per capita. So one of those interventions was conducted in community pharmacy and cost $52,000 per quality. The other was a home-based medicines review costing $113,000 per quality. 1 intervention could not be categorized because it assessed value as cost per change in degree of medication appropriateness and not cost per change in outcome. So this economic evaluation piece feels like a whole new world of deprescribing compared to the pragmatic trials section because we finally have some good news here, right? Community-based deprescribing interventions appear to be likely cost-effective when we use a time horizon of less than or equal to 1 year, consistent with the evaluations included in this analysis. The other really good piece of news is that incremental effectiveness was similar across studies included in this evaluation. The costs were where we sort of hit that variability piece, and those variable costs were driven by admissions, informal care, cost of medication, and of course the cost of the intervention itself. So there should be some consideration here for the methodologic quality of the evaluations included. Of the 13 studies included, or 13 interventions I should say, included in this analysis, 9 were determined to be of good methodologic quality, 2 were considered low methodologic quality. One of those was the evaluation that could not be categorized. And I think as researchers, perhaps thinking about measure sensitivity, are the measures that we're using sensitive enough to detect all potential value? And that's a consideration potentially for the evaluations included in this study. And also for deprescribing scenario, consistent with what Amy discussed relative to pragmatic trials, the number of medications per patient targeted by these interventions were somewhat more variable. Some of them targeted specific medication classes that may yield a different degree of benefit. Thinking about this setting where these interventions are being conducted, home-based medicines review versus community pharmacy. So there is some variability for us to consider relative to the deprescribing scenario. So how do we leverage all of these sort of updates to help older adults live happily ever after? Our goal anytime we're here in Disney World, right? So the first take-home point is that perhaps some medications should not be discontinued. I know Amy and I were really surprised when we sort of were digging into the statin literature, because we mentioned earlier, we tend to think that that's so common and so benign of a deprescribing target, but maybe in fact we sort of should be rethinking that behavior and rethinking that as we frame out deprescribing interventions for our research.
So similarly, we found that pragmatic studies of the multi-component deprescribing interventions generally weren't super successful. So unfortunate findings, definitely not what most of us in this room would have liked to see, but we did see some subgroup analyses and some other options for where we may be able to yield greater success in the future.
And deprescribing interventions, of course, did appear to be largely cost-effective. I think this is another bright spot. And I think another take-home message might be that maybe consider including some aspect of cost in evaluations that you might be conducting to further the economic evaluation literature.
And we actually didn't realize that there was going to be this big interest in complementary and integrative health related to deprescribing, but we actually have a pretty good hypothesis, is that singing animals are likely better for health, both physical and mental, than medications. And that is an open idea for a future research study.
So with that, we would love to thank you for the opportunity to provide you this update today, and we would love to take any questions or discussion from folks on the floor or researchers that we might have highlighted today. And yes, my 3-year-old daughter did elect for me to be Anna from Frozen for my final profile picture here.
Yeah, I don't have that excuse. I just picked my favorite, so.
So this is probably too big of a discussion for this meeting, but I just wanted to bring something up. I work with a lot of clinicians and I work with patients. I graduated pharmacy school a long time ago. And a long time ago, people were talking about what is the role of the pharmacist. It should be more than a dispensing role. And it's now like 40 years later, and I think that most people still see the pharmacist as someone who dispenses medications. And the reason it's relevant to your research is because maybe the problem that needs to be fixed is what pharmacists, how they present themselves to the public and how the public perceives them. Because I'll give you an example. Pharmacy counseling, let's say I get my drugs filled at Rite Aid, but I've been in Kaiser, so I'm comparing two totally different systems. But I don't see drug counseling as any different. It's very perfunctory. I've heard the pharmacist tell me things that I could read myself in the literature that is stuffed in the bag, or I could read in the package insert. And even more so, I've had the pharmacist tell me things that are not within my experience and actually strongly disagree when I shared my lived experience about a medication side effect. So I'm just saying that I think that issue has to be addressed, because if it was addressed, maybe the pharmacist's role in helping people deprescribe would be a better one. So.
Yeah, I mean, quintessentially as the, again, pharmacist in the duo, you know, there's the long-held belief of a product-oriented profession versus a service-oriented profession, and it's been a long-waged battle, and how do we change that perception in the public's eye and also amongst other healthcare professionals for what value pharmacists can bring to the table. And I know there's a lot of initiatives relative to pharmacy practice transformation and innovation that I think try to address that. And, you know, I think it's a great opportunity to consider for deprescribing practice and research, how we might engage with that sort of community pharmacy forward-facing, you know, healthcare provider, for sure. So thank you for the comment.
Hi, this is Jinjia. I have a question about the usual care component that you shared in your slides. When we talk about statistically or non-statistically significant, it has a lot to do with what is your usual care group. And I noticed in the studies that you share, some of the usual care have no explanation of what is contained, some of the studies I've read, the full text as well, is not really clear what is included. And some of the studies have usual care as, for example, HMR, the home-based review is even non-existent in some of the countries, including the US. So and also given that deprescribing is a multi-component and multi-step process. It starts from having a list for all your medications, and then go to reducing the errors in that medication, duplicates, discrepancies, and then go to optimizing that list. My question is, what do you think is a more appropriate usual care than medication review, maybe in deprescribing trials? Can we consider deprescribing as a all-inclusive process, and then we compare deprescribing with usual care that does not include a step that is considered already part of deprescribing?
So I think, if I'm understanding the question correct, is basically ensuring that any of the trials that we're looking at have an appropriate comparison group, right? Mm-hmm. That the only difference is the intervention itself. And in the studies, they essentially did try to do that as best they could, right? So like thinking about the one, like the home medication review, the patients, the pharmacists that were participating had to be doing enough home medication reviews in order to be included. And then similarly, the patients either got the home medication review or the home medication review plus the GMEDS report. So I think that as best we can, it would be great. Obviously with pragmatic trials, it's not going to be the same, right? Like in a lot of the pilot studies, many of them did show success, and I agree, obviously statistical versus clinical differences is another thing to think about. But in these more pragmatic trials where essentially a lot of the decisions about whether or not the meds got deprescribed were left up to the usual practitioner, that's where we didn't see as many successes in these larger trials. But I agree that absolutely you need to be thinking about an appropriate comparison.
I think that one of the questions that was you addressed is how much of the deprescribing recommendation get implemented.
Right.
Another portion is I'm considering, actually it's not bad news that we're seeing, it hasn't been as significant a difference as we're expecting. Perhaps we're comparing full deprescribing with partial deprescribing, given that medication review is already included as a control group, and given that in usual care that is rarely or not always consistently done. Yeah,
perhaps, yeah.
Thank you.
All right. Well, for the sake of time, thank you again. We really appreciate it.